you again for joining us this afternoon. Our next presenter is Janice Forster. Dr. Forster is a child and adolescent psychiatrist who specializes in developmental neuropsychiatry and is experienced in the management of medical, psychiatric, and behavioral manifestations in Prader-Willi syndrome. Dr. Forster will report on the use of pharmacogenomic testing for drug selection and dosing in patients with Prader-Willi syndrome. Thank you very much.
Okay, thank you very much, buddy. I appreciate your comments. Today, I'm delighted to be here finally. I am going to be talking on the results of a case series that was pharmacogenetic testing results in patients with Prader-Willi syndrome, looking specifically at deletion and UPD with the implications for drug selection and dosing. I'm the only one with a disclosure. So I'm trying very hard here. I want to talk about the objectives to understand the role of the hepatic cytochrome P450 enzymes in the metabolism of psychotropic medications, endogenous steroids, and nutraceuticals, to recognize the impact of gene polymorphisms on the metabolic phenotype of the cytochrome enzyme, and to comprehend the role of phenoconversion by dietary selections, lifestyle factors, drug-drug interactions, and environmental exposure. So just to review, the cytochrome P450 enzymes are a heme-based superfamily of proteins that are responsible for the oxidative phosphorylation of toxins, medications, and endogenous steroids. 80% of all drugs are metabolized in the liver by these 6 different cytochrome P450s. Familial transitions occurs via Mendelian inheritance of alleles, except for 2D6, because you can get multiple alleles from both of your parents. And also the cytochrome 1A2 has a special consideration for those with UPD. Pharmacogenomic testing is available commercially, and although genotypes don't differ across testing profiles, phenotypic function is a little bit different because it's unique to each company. So polymorphisms or gene variants produce enzymes with variable levels of function that affect drug metabolism. We're going to talk about 4. Ultra rapid metabolizer is related to increased metabolism of medication that usually requires increased dose or increased frequency of administration of medication. Extensive metabolizer is actually the normal metabolism. Intermediate metabolizer is slower metabolism of medication that requires decreased starting dose and slower titration. And the poor metabolizer status indicates very poor metabolic function with increased potential for toxicity that would then occur, that would cause adverse effects. So phenoconversion is the change of metabolic activity as a result of action at the cytochrome gene or at the enzyme. So at the gene level, we see induction at the promoter site. This usually takes 1 to 2 weeks to occur, and it will also take 1 to 2 weeks to dissipate if you identify that there is a problem. There is also competitive interaction of substrates at the level of the enzyme binding site. This effect is immediate, it is dose related, and it may involve shunting to other cytochrome pathways because many substrates are involved with other cytochromes, and so you can shift the metabolism to another pathway. Reversal of action depends on the half-life of the medications involved. And just to use an example of fluoxetine, which is Prozac, and cannabis, both of these have a relatively long half-life. And so if you have a drug interaction between the 2 of them, which is often, decreasing one of them will take a while for the effect to dissipate. And finally, drug activation can occur during first pass metabolism. That means that you create a therapeutic metabolite by an action of a cytochrome. So if you have a phenoconversion of that cytochrome, it can affect the action of the transition to the therapeutic metabolite, resulting in decreased function. So we heard yesterday about the issue of polypharmacy in patients with Prader-Willi syndrome. This is an extensive problem. It is definitely related to the mental health difficulties that our individuals have as a result of their phenotypic symptoms, their propensity to stress sensitivity, and comorbid psychiatric conditions. We have limited knowledge of the neuropharmacology of PWS, and we have minimal evidence base for selection of medications. There's an absence of studies looking at adverse drug reactions, and therefore we borrow it from efficacy studies in other developmental disabilities and from treatment trials of comorbid psychiatric conditions that may have nothing to do with metabolism in PWS. So I want to show you the PWS intervention pyramid. You've seen this before and you will see it again. So when a patient presents with mental health and behavioral difficulties, we jump to using medications to extinguish symptoms like putting water on a fire. But we lose perspective that there are so many other interventions that can be tried before we get to the medications at the top. And so we need to consider this because this is a classic problem that we see in PWS, and that is that medications are used to treat symptoms, then the dose is increased, they have more side effects, and then we use medications to treat the side effects. And before you know it, your 12-year-old son is receiving 6 different psychotropic medications, and he is feeling no better. And so this is why we decided as a group to look at this case series to see if there was some way of explaining why individuals with PWS tend to respond at lower doses than would be considered therapeutic in typical people, and also the fact that they have a propensity for adverse reactions. And so this is our case series of 30 referred patients that were evaluated in 3 regional centers. Referred means that they had failed trials of psychotropic medications, or they presented with complex comorbidities that would require more than one medication for treatment effect. Pharmacogenomic testing was obtained from 3 different commercial companies. Polymorphisms of genes were assessed, and the frequency of metabolic phenotypes was determined for PWS patients with deletion and UPD. All identifying information was removed, and you can see that these are the issues that were not present in our study. This is probably the biggest limitation of our results. So pertinent data, there are 3 other data sources that I want to identify. One was the original case series of pharmacogenetic findings in 35 patients that was published in Genes this year. We used the NIH PWS registry to identify the commonly prescribed psychopharm agents. This is similar to the PATH study, but a little bit different because there were 355 patients that were enrolled and followed over a 10-year period of time. We found that among those patients, more than half of them were receiving psychotropic medications, often in different combinations, and that 482 of them there were 482 different medications that were prescribed in this cluster of patients who were receiving them. So there were multiple evidences of polypharmacy. And then finally, I want to bring to your attention the table of substrates, inhibitors, and inducers of cytochrome P450. This is able to be downloaded. Please take advantage of this. This was originally derived from the Flockhart table of drug interactions, and then it was adapted for PWS and published in the Genes article. So just to review, a substrate is an agent, could be a medication, a steroid, or a nutraceutical that is metabolized by a given cytochrome. An inducer is an agent or environmental factor that increases metabolic capacity, and an inhibitor does the opposite. It decreases metabolic function, usually because of competition at the site of binding. So I'm going to use the 2D6 just to orient you to how I'm going to be presenting the next series of slides that talk about the results of the cytochrome testing. So what you see here, this is the frequency of the metabolic phenotypes, both in the normal population, in the combined population of PWS, specifically in deletion, and then also in UPD. This is all referenced by PharmVer, which is a big international consortium. And I will mention in each case, substrates, inhibitors, and inducers. In the case of 2D6, you'll notice there are no inducers because it's the only cytochrome that is not inducible. But I do want to bring to your attention, these substrates, according to the NIH registry data, are presented in the order of decreased frequency of occurrence. So to give you an example, 25% of patients were using fluoxetine, which is Prozac, and about half of those were using risperidone, and then it decreases accordingly across frequencies. So looking at 2D6, what we find here is that there is a generalized decrease in metabolic efficacy, especially among deletion, but also among UPD who have poor metabolizer status. This is important because it has direct impact on choice of dose of medications for these agents. 2B6 is the next one. We found that 2B6 was probably the most normal functional with frequencies that were very similar to the normal population, except there was a tendency toward decreased function in UPD, but it didn't reach the level of statistical significance. In 2C19, we see that there is also a tendency toward increased activity that is true for both deletion and for UPD. What you see here is an increase in ultra-metabolizing status for deletion, and all of our patients, 100%, had extensive metabolizer status, and no one had an intermediate metabolizer status among the UPDs. And again, please note the substrates and inhibitors. 2C9 had a different story. What we found here was that there was a generalized decrease, but only in UPD. The results of frequencies of metabolic phenotypes for deletion were very similar to the normal population, but UPDs had a decrease. For 3A4, we found that there was also a decrease in metabolic capacity. And this was typical for both deletion and UPD. And you can see that they all reached a level of statistical significance. So what's unique about 3A4 is that its activity, its expression is decreased by growth hormone. And there's a sexually dimorphic effect because it's selectively in males. So I promised you that cytochrome 1A2 was special, and it is special because it's also located on chromosome 15 outside the critical region, but nonetheless, it may be duplicated in individuals who have UPD. And indeed, in our series, we found that there were some individuals with complex genotypes with up to 4 alleles in the UPD group. 2 is typical. CYP1A2 is important because it is hyperinducible by dietary, specifically cruciferous vegetables. That would be like broccoli and cauliflower, the kinds of vegetables that are typically represented in the red, yellow, green diet. And lifestyle factors, such as caffeine ingestion or cigarette smoking, which we also see among our adults with PWS, and also vaping. And medications that are commonly used in Prader-Willi, so including insulin, modafinil, the antibiotics largely used for treating cellulitis, and the protein pump inhibitors. We also know that 1A2 has a lower functional efficacy in females than males, and it's also inhibited by estradiol. And one of the more interesting facts is that a particular allele, the STAR1F, is actually increased in schizophrenia and bipolar disorder. What we found was that there was a slight increase in both deletion and UPD, but it didn't reach the levels that were reported in the literature, which can be twice as high as typical. So that's something going forward to look at. Okay, so this is the data for 1A2, and what we find is that 1A2 is definitely leaning toward a higher level of metabolic activity. Look at the number of ultra-rapid metabolizers we have, both in deletion and UPD. And the hyperinducible type is more prominent among deletion. And what you need to understand is that if you get that allele, it functions as an extensive metabolizing allele unless it's in the presence of the inducer, and then it increases function. So these are the substrates and inhibitors for 1A2. Okay, so in summary, polypharmacy is a huge problem in PWS, leading to decreased efficacy of medications and increased adverse effects. The pharmacogenetic testing of a series of our referred patients with PWS reveals polymorphisms that are likely to affect metabolic function. Genetic polymorphisms were found in almost all of the cytochromes that affect metabolism of psychotropic medications that were used frequently among patients with PWS in the NIH PWS registry. Phenoconversion is likely to occur in PWS due to drug-drug, drug-steroid, drug nutraceutical, and drug lifestyle interactions with clinically significant effects. And cytochrome 1A2 has that special relevance to PWS because of its gene location, hyperinducibility, and duplications among those with UPD. So in conclusion, pharmacogenetic testing may be useful in patients with PWS to assist in selection of medication, to ascertain potential for drug-drug interaction and other interactions, to determine initial dose and subsequent schedule of dose titration, to understand the time parameters for medication response, and to identify risk for and profile of adverse effects. We need studies to describe to describe and quantify the frequency of adverse events associated with pharmacotherapy in patients with PWS. And we need validation of findings presented in this case series in a non-referred group of patients with PWS, and we're keeping our fingers crossed. So in the absence of pharmacogenetically guided treatment, please use previous recommendations to start low and go slow. Thank you very much. Sorry for the late start.
Fantastic job. Thank you so much. You're a pro, Jan. Always appreciate your contributions. We have some questions and we have a couple of minutes left. Were there any differences in body fat the patients referenced in the excellent presentation which might influence the drug volume of distribution?
Great question. And we were not privileged to that data regarding body mass index. But going forward, we will definitely look at that.
Certainly something you would want when you have access to the data, which is always a problem. What about family history as part of the study, and even just commenting on the importance of those factors?
Yes, definitely important. All of that information was absent. We only had the genetic data and regarding PWS subtype, and we had the pharmacogenetic data. Going forward, these are all really important questions.
So we had some basic questions of how bupropion can be a substrate and an inducer.
Yeah, and many of them are. Same with fluoxetine, which is Prozac. It can also be both a substrate and an inducer. I don't know why, it just is.
It's more to do with
some of the medications. Once you start them, they actually induce their own metabolism. So,
right.
Which makes it more complicated dose-wise.
It's a feedback kind of system. So can you clarify EM, IM, PM designations on the slide? Can maybe go through that again for people because that's an important designation.
Yeah, do you want me to go back and see if I can find it? So
yeah, sure. We have about a minute, so we have to wrap up pretty quickly.
Okay, so ultra rapid metabolizer means that you have increased metabolism of medication. That chews up the medication in your system that results in medication, like the half-life is actually decreased. So what happens is you have to have an increased dose or you have to dose the medication more frequently through the day. If you're an extensive metabolizer, you have normal metabolism. If you're an intermediate metabolizer, your metabolism is slowed and it requires a decreased starting dose and an even slower dose titration. And poor metabolizer status is ominous because you have very slow metabolism and it with increased potential for toxicity because you keep, if you don't know it, you keep dosing at the same frequency and the medication just keeps accumulating and accumulating and then you become toxic with adverse effects.
Fantastic. Thank you so much. This was a great presentation. Sorry for the misdirection early on, and you did a fantastic job. And we always appreciate your contributions. Beautiful work.
Thank you very much. Thank you.